Welcome to The Local Lens. I'm Jenny Pastusak. I was reading an article in the Salisbury Independent about a grant that the city of Salisbury received that's going to help bring better health care to people in the community, in their homes. So we took The Local Lens to the Salisbury Fire Department to talk to David Phippen, SWIFT coordinator, Jessica Stoner with Tidal Health, and Salisbury Fire Chief Robert Frampton. So David, let's talk about SWIFT, because this, from my understanding, you're a SWIFT coordinator, but you're the founder, correct?
Well, I don't think I brought it to Salisbury. I'm not the originator of community health by no means, but yeah.
What is it?
SWIFT is, I like to describe it as a community health partnership. The main players being Tidal Health and City of Salisbury Fire Department, with a lot of other community partners to navigate, help patients navigate the healthcare system and deal with social determinants of health to make them more independent, so they're not relying on EMS, the emergency department, things like that.
Now, where did this all stem from? Because you brought it here.
Yes.
But why?
Why? Well, working on shift is, riding the ambulance every day, or you have your frequent flyers, your multi-visit patients, whatever you want to call them. And one day I just happened to be on an ambulance, and we were at the hospital. The engine crew went to the patient's house first because we were going to be a little delayed. And they had been there probably 3 times, in the last couple of shifts, and they were less than nice to the patient, I thought. Not they were unprofessional, but I didn't think that the way she was being treated, she actually deserved. Mm-hmm. So I said, there's got to be a better way. I said, this is a disservice to the citizens of Salisbury. So why don't we come up with a plan to help them instead of, belittle them for going to the hospital all the time.
Right.
And that started the wheels turning and the balls rolling. And about a year and a half later, I was able to present it to the fire chief and got the okay to pursue it.
Okay.
Started having meetings with some hospital executives, which is way out of my comfort zone. But somehow they agreed to let us do a pilot program for 6 months, and here we are 8 years later. We're still, I guess, in a pilot program because it's going strong.
That's great. And so what you were seeing was that people just kept going back to the emergency. They're like, look, that's the place we go when we need help.
Right, and that's was created by the fire service back in the 70s when 911 was developed. We told everybody, if you got a problem, call 911.
Right.
Well, that's what people were doing. And now we're saying, no, please don't. The hospitals are overcrowded. So there had to be a better way. And we think this is helping. I mean, I know it's helping, but our call volume keeps going up. So the numbers of calls don't go down,
right,
but the number of times these patients go to the hospital goes down.
That's important.
Yes. So
very important.
Most are usually in 3 months for a frequent flyer, their calls go down by at least 30 to 40%. So.
Okay.
And their ED visits, and so.
And you're bringing health care to them, in a sense.
In a sense, we're helping them navigate the healthcare system, find healthcare on or we help them find primary care or transportation or whatever their social determinant issue is. We do some health care for some shut-ins or people that have, we will bridge the gap between, no primary care to primary care, like, because, you call primary care office and you're 3-4 months out. So
yeah.
Some people need a little bridge, and we will do that with our nurse practitioners that we have.
Are people hesitant to let y'all come in their houses?
That's the great thing about this program.
Okay.
Everybody trusts the fire department. We're probably the only profession that, in 5 seconds, we have gained complete trust of everybody we see. And that's the beauty of the program. Mm-hmm. I think there's been a lot of people try community health, and I know the hospital tried going out and door slammed in their face. And
yeah.
I've never had anybody say, no, we can't come in, ever.
It's not only just a pilot like this is 8 years later.
Yeah, I think this is here to stay. I think this is the future of EMS. I think we're going to be a very valuable asset to the healthcare system because we do have that access, and we know what's going on in people's homes where, people go to primary care, they don't actually tell their primary care doctor, they got a big hole in their floor, they got bugs crawling up their walls, or they don't have any food in their refrigerator. We see that firsthand. So I think we are on the front line of healthcare, and I think it's here forever. I don't think it's going away. At least I hope it's not.
So the city of Salisbury and the Salisbury Fire Department was awarded over a $500,000 grant.
Yeah.
What is that money for? What's going to be done with the money?
Yeah, so the money comes from opioid restitution funds. So individuals that lost their lives back when OxyContin was being written in the first wave of the opioid epidemic. So individuals that lost their lives, there was a big lawsuit. So now the money is going back into the community to educate people and to treat people with opioid use disorder.
Okay. But what does that look like? I don't know, what kind of treatment and services are we talking about for the people out in the community?
Yeah, so it's a full 360 of everything, right? So you can take medications for opioid use disorder. So EMS is going to be able to do buprenorphine induction. So say an individual overdoses or they're trying to seek treatment, EMS can be the first start them on this medication called buprenorphine.
Okay.
And then they can follow up with different resources in the area. So MAT clinics, the crisis centers working on developing things. So that's one part, just the medication-assisted treatment. Then you talk about the social part, right? So do they have transportation to get anywhere to see these clinics or to follow up primary care? So that's what some of the money is going to be, to help to make sure they have transportation. Can they afford their medicines? All of those things along the lines. We're also working on a lot with harm reduction. So harm reduction is resources that make it a little bit safer for those who may be using or have an opioid use disorder. So making sure that Narcan is available in the community, that somebody doesn't have to go buy it, they can come and pick it up. We're also providing test strips. So patients that may have used cocaine, they're now getting laced with fentanyl or xylazine and they don't know. So we want them to be smart when they're using so that they don't experience an overdose and they're unaware that those medications are in there. And then other things too are drug take-back days or medication pouches. So say you had a knee surgery and they gave you 7 days of oxycodone and you used 2 days. What do you do with the rest of the 5 days? We don't want them sitting in your cabinet. We want you to take them back to pharmacies like Title Health in the ER, or to have a doTERRA bag that we can hand out to patients that they dissolve the pills right there in the bag, and then they're not available for use anymore.
Because that's when they become abused.
Yes, yeah. Like leaving them in your cabinets. You get concerned for the individuals that have a disorder and they may go through cabinets and use or prompt someone to start using.
And I'm gonna touch on something, and if we don't need to go there, we can just not include it. There are people who are saying, "Oh, you're gonna make it safer for people to use drugs." What do you say to that?
I say it's a disease like everything else, right? So we think we're treating patients with buprenorphine, but we treat patients with diabetes with insulin. So I kind of look at along those same lines, right? We want patients to be safe. We don't want patients to use dirty needles and then be an increased risk for HIV or hepatitis C and then expose other individuals in the community. So you have to meet your patients where you are and make sure that you can provide them the best care and the safest care. And it's all different for all different diseases.
And it helps the whole community.
Yes, yeah.
In the long run.
Yeah.
Something about the schools. Are you doing some education in the schools?
Yeah, so we're really passionate about the schools. So if you look at the data, it says by the age of 6th grade, around 12 years old, that they've already had some kind of experience with opioids. So we look at what the schools are doing. They're doing a great job educating, but how can we help to assist? Will it be more beneficial coming from a medical professional or the paramedics that are on scene to come and educate them and making sure that they know that they may see it in their community, but we don't want them to follow down the path of having a substance use disorder.
Right. So just a little more exposure to what it really looks like in the real world.
Yeah. And that there's treatment out there, and that if they want to have help or their parents need help, sometimes kids coming home and talking about their parents about, hey, we learned about this. It's increasing the education of our community overall.
Let's talk about the healthcare role in SWIFT and actually going with the fire department or with EMS to people's homes to see them, see what they're dealing with. Talk about that a little bit.
Yeah, so it's a really unique program. So when you respond on a 911 call with these individuals, they say nurses are the most trusted profession, and I told you that earlier, but the fire department is as well, because these individuals are going to anybody's home, the door's open, they're ready for help. So we have a very unique experience, and the nurse practitioners do as well. So we have these conversations. Are you taking your medicines? Do you need a refill? We could refill them right at that time or get them into care. So it's a unique opportunity. For a while, we used to cold call and just knock on the doors and say, hi, I'm a nurse practitioner, can I help you? But EMS has been the best forefront way to get into these people's homes and make those relationships, and there's already a level of trust from the EMS, and then there's a level of trust with nurses too. So we kind of have a twofold great thing going on.
But when you walk in that door, you get to see so many other things.
Yes.
What are you looking for?
It's eye-opening. Sometimes you're not looking and it just kind of appears. So I always say your patients will tell you one thing when you were in primary care, and I'd say, are you taking your blood pressure medicines? And they say, yes, they're taking it. And then you enter their home and they can't find their medicines. They have an old pill bottle, all different things, right? You look in their fridge, they have no food in the fridge, they have no transportation, and you're wondering what's going on. So It's really eye-opening. Your patients don't have to tell you as much because you observe so much. And then they're kind of more willing to talk about it when you're there. And you're like, hey, do you have your insulin, or do you know where your glucometer is, or could we help pill pack? Because you can see that they're struggling. And then they're at a vulnerable spot too if they're calling 911. A lot of people don't like to call. So by the time they hit that spot, they really need help.
We talked about SWIFT and we talked about the grant, but I'd like your perspective on some of the roadblocks. Basically, let's talk about roadblocks before we talk about all of the different programs and services.
Obviously, the biggest roadblock in all this is communication and working relationships between the different groups. There's so many different players and they have so many different roles that it's keeping everybody cohesive and together and happy and managing, personalities, and people want to claim things as their program, and but it's a joint community effort overall. But that's one of the biggest things that I think between especially the hospital and the fire department leadership is making sure that everybody else that are our players realize that we kind of lead this program and guide it, but then there's the other allied agencies that are more of the helpers that help when we need them.
Because it could be someone needs, transportation, and you would need to hook
transportation, or they might need, PT in the home, or they might need access to a dialysis, physician or clinic for that, or they might need food, or they might need a grab bar or a wheelchair ramp or something like that. So knowing what players to reach out to, but also knowing that this is a huge relationship between the hospital and the fire department, and that's what drives this thing.
And maybe sometimes people don't even realize how much they really need until they're finally at their wits' end.
It does. It takes a lot for people to admit and want and seek help. There's a lot of pride in being able to take care of yourself and do things on your own, and you've gotten out of problems your entire life, and you're going to get out of this one. And there's no shame in asking for help,
right,
and from getting help from anybody. That's what this group is here for. And we don't judge anybody in any way, shape, or form, and we're willing to help any and everybody.
Have you seen the numbers? So David talked a little bit. He was talking about the frequent flyers. Have you seen over the years the improvements?
Oh, definitely. And the improvements are when I stop hearing the crews talk about the same people that they've gone to, that they know on a first name basis, or they know an address. 123 Main Street. Oh, we're going to see, Mrs. Jones again. And, they go out there and they do their job. But then when I quit hearing about Mrs. Jones, I'm like, something happened. And you find out that SWIFT got involved, and lo and behold, Mrs. Jones doesn't need to call 911 anymore. And she's still monitored and observed in our program should she enter the healthcare system again. But, really, we don't hear about our providers talking about it anymore. And that's when I know that we've made a difference.
Well, I think it is important to know the backstory of someone, because then you're like, well, they did this and this in the past. And you kind of have to know the history, right?
Yeah, you do. Definitely. And another thing, too, that we're just starting to look at is this SAFE initiative with regards to falls. So the fire department responds to about 1,400 EMS calls a year for people who have fallen, various levels, from ground level fall, falling out of a chair, to falling off of a ladder. not all of these people need to go to the hospital. A lot of times they just need to be picked up and put back in their chair or helped up because they live alone. So our crews were going out to these calls ends up usually not being a transport, and it's a large cost for us. So what we've done now is we've created this program where we will then, our SWIFT team will then follow up with them same day, afternoon, next day, wherever it may be, to identify hazards. Maybe they need glasses for sight. Maybe they can't see where they're walking. Maybe they've got rugs or extension cords or something in the home, so they're falling out. And then should they need help afterwards with regards to like physical therapy in the home or in clinic, we can go about there. So it's just a hazard identification as well as a balance assessment, fall risk assessment, and all those kind of things. And we hope to make an impact on those 1,400 calls by lessening them, which then reduces the cost that the fire department's just putting out for somebody who just needs help up, back into a chair or something.
It's more preventative for the second time around. Can we talk about the proximity of people that the SWIFT is going out to?
Yeah, so right now, currently, obviously our primary focus is the Salisbury Fire District, but we have MOUs with every fire department within Wicomico County to allow us, should they refer somebody in, to go out into their fire district to see if that patient wants to become a part of the SWIFT program. So even though it says Salisbury-Wicomico, the Wicomico is the ticket there that gets us to the county, and it's primarily the Salisbury Fire Department people and personnel and equipment that would go out to, say, Parsonsburg or Powellville or Willards or Hebron, for that patient who's referred to them. We still go out and do that, and we still, David and his group still go out and make follow-ups. So it truly is a county-wide effort and not just the Salisbury Fire Department, even though our name and our people tend to be the ones that people associate with it. So,
that's fantastic because there's a lot of people in this community that are outside the city limits. What about can we talk about other programs?
Sure. We've got, obviously, the SWIFT program, and then we have the MDCN program, which is Minor Definitive Care Now, which is our low acuity 911 calls that the nurse practitioner, community paramedic respond on. Many people may have seen the purple one pill can kill Narcan car riding around town. Part of what they're doing, in addition to the opioid education overdose outreach, is they're also responding to low acuity calls to help maybe treat a person in their home so that they don't even have to be transported. So they have the ability to draw blood, get lab results within just a few minutes. We have contracts with mobile x-ray company to come in within 30 minutes should somebody say they roll their ankle and we're not sure if it's broken, whether they need to go to the hospital or whether it's just a sprain, and they can follow up with PT or something later. They'll come in and do a mobile x-ray. We can prescribe prescriptions. We can go to the pharmacy and pick up prescriptions and bring them back. We can give sutures. So if somebody simply cuts their hand, they call 911. We can give them an antibiotic infection. We can give them, whatever other, injections that they might need, stitch them up, and they don't ever have to enter the hospital. So that's the MDCN portion of it. Obviously, the opioid, education and response for that is another large part. The Safe Fall Initiative is part of their program. And then the buprenorphine program that's getting ready to come to life here. Those are all kind of things. And then, where does it go from here? I really see this mobile integrated health as the overarching name for these types of programs. And that is the future of EMS, is to keep people out of hospitals, out of primary, care, physicians, facilities, out of urgent care, keep them in the home, let them stay where they're at and treat them there. Kind of going back to the old, when the doctor would pay your home visit.
That's what it makes me think of.
And going back to that just on a totally, more technologically advanced level nowadays. So I see MIH, probably not in my career, but in the next 20 to 30 years, being more busy and have more units than, say, your traditional transport EMS unit. That's just my personal opinion of where I think this is going to grow and go to. There's legislation that's being worked on from a billing perspective, because that's usually what ends up being the problem, is funding or lack thereof. And it's because these practices are so new that there's not a lot of insurance support for them yet, but it's coming. And there's also Medicare, Medicaid legislation that's coming that will allow agencies to bill. Currently, our fire department, because we are not attached to a hospital, we cannot bill for MIH services, but the nurse practitioners can.
Okay.
So the hospital is able to recoup some of that money. By no means does it pay for the services of 2 nurse practitioners,
Right.
and our team, but it allows them to recoup some of that money. But there is some legislation that's making its way through that will allow us to hopefully bill for some of these community paramedics of the work that David and Miranda are doing, so that we can recoup some of it. We'll never make it back. It's never a for-profit thing. EMS in general is not for-profit. It's not intended to be that way. But just to recoup some of the base expenses would be nice.
Well, and part of this grant is to help support people's salaries, right?
Right, and without these types of grants that help us to extend services, extend hours, we wouldn't be able to do these programs because they're just, the funding is not there.
Right.
From a local, state, and federal level. It's just not there without these grant funds. And the problem is they're getting more and more competitive. So there's still grants out there, but there's, instead of it being 1 or 2 MIH programs in the area that would apply for them, now there's 8, 10, 12, 15 MIH programs. Every county and every department's almost standing up their own mobile integrated community health program. So it's more competitive for the grants. So they're few and farther between, which then makes the financial part of it fall back on the municipality or the department or the hospital.
Do you get feedback from the community?
So we do. The program, everybody who has been involved with the program and has been either a patient or been a family member of somebody who's been in the program raves about it. We're currently in the process of trying to capture that data in a little bit more than just hearsay.
Yeah.
So Miranda, who's our community paramedic and is on our MDCN team, is working right now to create patient satisfaction surveys that we will give to any patients, whether they are somebody that we interacted with and they ended up being transported, or somebody that we just make routine visits to, just to find out, hey, what do you think? And then what does their family member think of this program? But we've had we've had elected officials, family members, and it's like all kinds of walks of life. It's everybody who reaches out raves about the program and the successes of it, and I've never heard anybody say anything bad after they've had an experience or an introduction with the program.
How about your team? How about the people going out there?
I love them.
Yeah.
Yeah, they're great. They're great assets for the fire department because so many of our calls are time sensitive. They are, somebody's house is on fire, somebody's having a heart attack, let's rush, let's get them there. All right, 10 minutes, 20 minutes, all right, take them to the hospital, this is what we need to do, dump them off, gone. Our SWIFT team is able to go out, they're able to come into the home, they're able to spend an hour and a half in the home, learning about the patient learns about us, our services that we can offer. And just we can just educate them about healthcare in general, about some things in life, some changes that they might need to make in their life, and then just all the alternative things that are out there from a patient care and standpoint. So it's a lot more personable. David has people that call his cell phone on nights and weekends, sometimes just to talk. They're lonely. But what that does is that reduces a 911 call, because we have had people who have called 911 for they can't change their oxygen tank out, or it's a Saturday night before Christmas. They're just lonely. They don't have any family, and they just wanted to see such and such a crew, and most of the time they know who that crew is because they're such a frequent flyer that's they call, and our crew would go out and spend 15 or 20 minutes with them and say, all right, Mrs. Jones, we've got to leave now, we've got another call, and then and that's tough. It's tough to see people that are like that, and that's all they want is just someone to, a lot of times, just to talk to, share a problem or a concern, or just whatever it might
Feel
be.
cared about.
Yeah, just that somebody was on the other end of that phone. They came out and they visited me, and they're probably going to talk about that for 3 or 4 days.
Yeah.
But the team is wonderful. Without Tidal House Partnership and the fire department working together, this program would not exist. We both need each other to make this survive. And that's, I think, why it's so successful, is because there's such a commitment from the city of Salisbury and the Salisbury Fire Department and Tidal Health on both ends to make sure this is a success, because we all see the value of it. And like I said, anybody who's been touched by the program can speak to the value of it. So,
thanks, Chief, so much for letting us come out and talk to your team today.
Absolutely, it's always a pleasure. The program is top notch and one of the best. We love talking about it. So anytime, more than welcome.
I want to thank the fire chief and the SWIFT team for having us and for all the good that they're doing in our community. You're watching The Local Lens. I'm Jenny Pastisak. See you next time.